What's up, everybody? Sam Carlson here with Patient Stream. Welcome to New Patient School. Today, I'm like super excited. You know, I get excited for these trainings every week, but I'm not gonna lie. I got the slides for this training. I was like, crap, I got to put together a quick email, shoot it out, and see if we can get some more people on because this thing is going to be so much fun. And Andrew and I last week was not funny, but funny, I guess. We did a training and the video, the file got corrupted. So I'm going to actually this week, I'm going to record audio and video. Anything can happen. So I just wanted you guys to, I wanted to give everybody a chance to show up. And I know Fridays are not the best days, but we're working with what we can here, folks. And if we need to adapt the timeframes that we're doing these, we will. But welcome to Patient Stream. My name is Sam Carlson. My co-trainer today is Dr. Andrew Wells. We're super excited to have you here live. I'm going to go ahead and record. Boom. There we go. We got the audio going too. We're super excited to have you here live. And today we're going to be doing a live role play on basically a day to an enrollment process, a report of finding process. And this is a continuation of previous trainings we've been doing between getting leads to turn into shows, to turn into educated patients, to turn into closed and enrolls patients. We've been doing these trainings now for, I think, almost 5, 6, 7 weeks, something in that realm. And I feel like this one right here is going to be one of the most engaging and as far as tactics, this one's going to be loaded with tactics. So thanks for coming, and we're excited to get you guys started. I wanted to let you know what you're here to do today. While I do own a company called Patient Stream, that's not today's goal. Today's goal is to show you how to get new patients. Okay, our goal is to help docs grow their practices by providing, obviously, our amazing software that allows you to run your own ads. It's a DIY Facebook marketing software, and that's really exciting. It's great for us. We want to give you the best training. Okay, this training is free. This is not, you're not paying for this training. This is something that we want to do because we know that in the long term, in the long run, if we help you get more patients, that just helps. What is it? A rising tide lifts all boats. So that's kind of the school of thought we adhere to. And we also, our goal is to create a community of docs with drive and passion to get new patients. In fact, we've got docs on this call. Dr. Del Rio, he's on this call. I and Michelle Sims. I've recently done trainings and interviews with them where they are transparent about the things they're doing to have the success. And I'm hoping that with Patient Stream, we can just share tons of transparency, show you guys what works, what we're doing to have success. And, you know, again, a rising tide lifts all boats. And we want to make this easy. Okay. That's a dodo bird, if you didn't know, and dodo birds are dumb. And so if we can make it so easy that even this dumb dodo bird can do it, then, and that's why he's our mascot for New Patient School. Okay. I'm going to jump right into this. A lot of times I'll fill these, you know, I'll just give announcements about Patient Stream, what we're doing right now. Obviously we have a ton of new niche offers that we're uploading. It's crazy. January is going to be crazy, to say the least. But I want to get into today's training because I don't know, maybe I'm more excited than you guys. I don't know. But I'm really excited to get started. So I wanted to introduce, if this is your first time, I want to introduce you to our trainer. He's a good friend of mine. His name is Dr. Andrew Wells. He's an awesome guy. He's the owner of a company called Simplified Integration, which basically, if you want to integrate your practice, you want to do it seamlessly for a way lower price, reach out to Andrew. He can help you do that. Okay. He's also got a Simplified Integration podcast. He's a lot like me in that we feel like when we share and we teach and we kind of hold nothing back, at the end of the day, that will, you know, that good karma will pay off in the long run. And again, the most important thing, I've said this before, I know him, I know myself. Our most important job is as a father and husband to our families. And so I know he is that way. Obviously, he's got his lovely wife and 2 boys here. And I know he's an awesome guy. So Dr. Wells, I'm going to go ahead and have you unmute. How you doing, buddy?
Great, man. How are you? Can you hear me?
Yes, I am doing good. And I should also, I didn't mention this last week, but I should mention it because I think it is noteworthy. Thank you for doing this. I know that right now is not the most keen time for the Wells family. You have, you've got that stinky Rona thing, and I think your wife just got it, and that's no fun. So thanks for doing this and for following through. We really appreciate it.
Yeah, man. Thank you for that note. I appreciate it. I really don't like to miss these meetings because I know they're valuable for people, and I really appreciate the people who are on here. I was diagnosed with the coronavirus, and then I had 2 positive tests, and I felt kind of crummy and lost my sense of smell and all that. But that created a whole set of issues, and then my wife got it, which created a whole nother set of issues. So my wife owns and runs a small business, as do we, and our kids are not in school, so we're trying to juggle this really wacky time right now. But the good thing for me is I get to be out of my house for like a minute, and this is actually a good break for me. So thanks for having me.
No, we love you, buddy. So I'll go ahead. We'll turn it over to you. I've got the slides. I looked at the slides, and so I'm ready to do the role play. I'm excited for this. But as far as, I don't know that I'll be able to anticipate some of the slides. So just give me a click or something for your next transition.
Yeah. So for you guys, docs, just know that like Sam and I have not role played the role play, and really, in thinking about this before I got on, I really, at the end of this, just to kind of set this up a little bit, my hope is that at the end of it, you guys are gonna be like, that's all it is. Like that wasn't very special. And I really honestly hope that you think like, yeah, that was really simple. I could do that. What you're not going to find at the end of this is like, there's some sort of magic line or like magic delivery or special sauce that will give you a higher conversion in your reported finding. It's totally not that. And I've said this over and over again. If you guys have done a good job with your intake and your day 1 process and your follow-up, this day 2 process, this report of findings, should go really smoothly in just reporting what your findings were from day 1. And so I think this will be somewhat anticlimactic, but I want you to know that in this scenario, less complicated, less fancy, less tricky, the simpler this process is, the report of findings, the easier it's going to be for you and the better your conversion rate will be. And I hope you understand that. And so this dawned on me this morning. If you click to the next slide, if you would, Sam. I created this morning, and this is something that's been rattling around in my noggin for a while, and I was finally able to articulate it. And this is where we find the docs that convert at 80% or higher, or aren't converting very well at all. We can pin you somewhere on this matrix. Now, there are 2 components to a quality report of findings as the doctor or as the case manager. There's a competence component and there's a confidence component. And what I mean by competent is that a competent doctor is a person who has good clinical skills. They can articulate the what in terms of the diagnosis and the therapy, and they're that's like the clinical side of it. So you know what you're talking about, and you're strong from a clinical standpoint. The other end of it is the confidence part. And what I mean by confidence is how well are you at articulating what's in your head and what you know to actually to relaying that to the patient and getting the patient to understand it. And that has everything to do with how you walk in the room, how you respond to questions and concerns, your verbal communication and also your nonverbal skills. These are the things that patients are picking up on and they're noticing. And so you can have the best scenario would be someone who's competent and confident. On the other end of the spectrum, the diagonal part and the red part on the bottom right, you have an incompetent, unconfident doctor who, this is a person who just doesn't know what they're talking about, and it comes off as unconfident. And that's pretty rare. But what happens is, let's say you've just done, like, launched a new therapy, or you're a doc fresh out of school and you haven't really practiced your skills so much. You walk into the report of findings and you stumble over your answers. Maybe there's a lot of there's a lot of, like, just hemming and hawing, and the patient will detect that instantly. And then you have, more often than not, in the upper right hand corner, you have docs who really know what they're talking about, but they don't come off as confident. And this is a hard one to pick up on. In fact, a lot of doctors don't know that they're in this box. So they really know their skills, but from the patient's point of view, they don't seem like they have their stuff together. And I would say a lot of docs fall under that category. And then finally, you have in the lower left-hand corner, you have doctors who are incompetent, meaning they don't know what they're talking about, but they come off as, they have the ego problem. Like, they come off as like, I can, no matter what the problem is, I can help you. And they're going to kind of ram the patient through the report of findings process. Yeah. So what we want to do is get a situation where you're competent and confident. And the only way I know to do this, so you can teach the competent part, right? You can teach protocols, you can teach therapies. That's a very formulaic system, but oftentimes you find that it's tougher to teach the confidence part. And the only way I know to teach the confidence part is just by role playing and training and repetition and repetition, repetition. And this is where a lot of, I get this kickback sometimes where doctors say, hey, Dr. Wells, I used your script. I said your script verbatim. I followed it to a T, but the patient didn't commit, or they didn't show up for their appointment. And what they're missing here is, it's not what you're saying so much as how you're saying it. And that's what I really want to get across today, is that how you come across to the patient has much more to do with what you're actually saying. So yes, scripts are important, and we use scripts and we're advocates for scripts, but so often doctors take that in a very literal sense, meaning that if I just follow the script, I'll be okay. That's not it. That's part of it. And the reason I talk a lot about training and role playing with your staff is because unless you do it, and to be honest, I got competent and confident when I was about maybe 1,500 report of findings in. So the first 200 were a train wreck. When I got to about 500, I was like mediocre. I have a notepad, a little sticky pad in front of me. On the sticky pad, it says average sucks. And when I started out, I was very, very average. But the more I did it, the more I trained on it, the better I got. And the takeaway from this slide, what I want you guys to do is that when you're training and start to train on your day one process, and especially your report of findings process, what we would do is in our office is we would train on it. We would role play just like Sam and I are about to do. And at the end of the role play, I gave my staff orders, directions, and 100% confidence that if anything that I said during that process was awkward or didn't sound congruent or my head wasn't in it, they had to call me out on it. And it's funny, man, we had a lot of fun with it, but they got really picky on what they were noticing. Like, hey, Dr. Wells, your hands were in your pockets the whole time. You didn't look very confident. Or you seem to be like over exaggerating the benefits of what you're talking about, or you're using hyperbole, or you're inflating the results. If they ever sensed that I was being inauthentic, they would just stop me and I would have to fix that part of the report of findings. And there's a lot of nuance there, but give your staff the authority to do it, because it's very hard to self-regulate that. A lot of doctors think, oh, that was great. I'm doing such a good job and I'm so well practiced and I'm the bee's knees when it comes to a report of findings. But you really need to have an outside perspective on that process if you really want to get good at it. And so that's the takeaway, is that role play, train on this process. And here's my, I haven't done a report of findings in like 3 or 4 years. So what you're going to see here is you're going to see me go through this process as a competent person. But what you're going to notice is that because I haven't practiced it I haven't done it in a long time, you're going to notice that my confidence levels are not where they should be. So I am by no means report of findings ready if I had to do one today. But I just want you guys to understand, as you're going through it, like you'll see in this actual training that, man, like Dr. Wells is kind of stumbling a little bit there, for a good reason, because I just haven't trained on it in years. I can help people train, but I really have not been in the trenches doing this for a long, long time. So you're going to see a little bit of that lack of confidence in me when I do this. And
especially after I like trip you up.
Say again, bud?
I said, especially after I intentionally trip you up.
Yeah. So I hope. Just kidding. Yeah, no. I really hope that you do. And I gave my, for our staff, I told them, I want you guys to give me difficult objections. sometimes they're like way out of left field. Sometimes they're the typical objections like, wow, I don't think I can afford this, or that's way more money than I thought, or why doesn't my insurance pay for this? Like, you should have your staff ask you these tough questions, because until you learn how to hit those curveballs, you're going to stumble in the real situation with patients. And so, it's my hope that you can trip me up. That's the whole goal of role playing. Yeah. And as we're going through this, docs, use the chat box. So at the end, what I want you to do is you can spoon feed Sam some objections. So if there's an objection, doc, that you're getting on a regular basis and you want to see how I would handle that, just type that in the chat box, and then Sam will tee that objection up so you can see how I would likely handle that in an office setting.
Perfect. All right. So should we set up what we're doing next slide, or you want to set it up first?
Yeah, let's set it up. There is, so we're going to be, Sam, you're going to be suffering with left knee pain. And you've had it for 5 years. You've done cortisone injections. You've done physical therapy. You've done hyaluronic acid injections in the past. And the diagnosis is you have osteoarthritis. The therapies you did before offered some pain relief, but it seems like it's getting worse over the years. And now you recently had a consultation with an orthopedic surgeon, and the orthopedic surgeon told you you're too young to have surgery. And the goal here is just for you would be pain management, and to at some point you're going to have your knee replaced, but probably not for like another 15 years. So that's kind of the scenario.
Okay. I'm ready for it. And what's kind of eerie about this is, other than the age part of this is my dad's situation right now to a T.
Oh, okay. Perfect. This is actually a really, really common situation. And what's your wife's name, Sam?
Morgan.
Morgan. That's right. All right. So we're going to role play this. I'm going to try to not jump out of character as much as possible, but I may at some point, just to explain a couple things. And Sam, if you have any questions that you think you'd explain, just interrupt me and let me know.
Perfect.
Hey, Sam, welcome back to the office. It's great to have you here today.
Thank you.
This must be your wife, Morgan?
Yeah.
Hey, Morgan, nice to meet you. Really glad to have you here today. And Morgan, first of all, I just want to say, thanks for being here. You may wonder why we wanted you to come here today. And what we've found over the years, and we've helped thousands of patients with knee pain, is that spouses almost always have questions. And we wanted you here today to, number one, understand what's happening with Sam's knee so that you know. And also, we're going to go over some recommendations on what we can do to fix this problem. We're going to cover your insurance coverage, any out-of-pocket costs. And what we found is that when spouses know, when you know what's going on with Sam's knee, not only will you be informed, but you're in a better position to support him in the care that he needs to get better. And number one, this saves you guys a lot of time. It's really hard for Sam to go home and explain all the details and the nuance of what we're talking about today. So we just want to thank you. I want to thank you for being here today to support Sam and to understand the therapy and how we're going to help your husband get better. So thank you for that.
She's excited to be here. I'll just say she's nodding. She's got a big smile. She's very pretty. So she's excited to be here.
I've seen pictures. Yeah, she's very pretty. And thank you. Yeah, thank you, Morgan. We appreciate you being here. Sam, before we get started, do you have any questions, like anything that you want to get off your chest, or major questions that you have before we get rolling?
No, I think are we going to talk about money today as far as cost and what my insurance and all that kind of stuff cover?
You got it. Yeah. So the way today works, what we're going to do is I'm going to start off by showing you what a healthy knee looks like. And then I'm going to show you what your x-ray looks like. And then I'm going to have you actually show me what's good and what's bad on your x-rays. And the reason we do that is I really want you and Morgan to understand and get a really firm grasp on the issue that's causing your knee pain so that you understand it. And then from there, what we're going to do is I'm going to explain what therapies we have in place that will help you with your particular problem. And we'll talk about what therapies we're recommending, how long it'll take for your knee to recover. And then at the end, we'll talk about what your insurance covers. We'll talk about any out-of-pocket costs that are involved, and we'll answer any questions you have about care, specifically your care, what it costs, and what's involved.
Okay.
And at the end, if you have any questions, we'll be happy to answer any questions that you have. And it's pretty straightforward. And I do want you to know, Sam, so there are a lot of the therapies that we're going to talk about today are covered by your insurance. There's one therapy in particular that's not covered by insurance, but I want to present this as an option to you so that if you decide that, so at the end of this, you can say, hey, Dr. Wells, I just want to do what my insurance covers. That's totally cool. Or you can say, I really want to do whatever it takes to fix my knee. And I'll present that option to you, and you can decide at the end what you want to do, and what makes the most sense for you guys.
Okay.
Does that make
Okay,
sense?
cool. Yeah, that's cool.
Okay. So the first thing I want to do is let me give you some context for what a normal knee looks like. And so this is where, so if you look at this poster here on the wall, there are 4 grades of osteoarthritis. And I'm going to show you your knee in just a minute. But the reason I want to show you this is that there is what's considered mild arthritis, and there's what's considered severe arthritis. So on the left, what you're looking at is grade 1 degeneration. And this is when the 2 bones in your knee start to, the space in between the bones starts to become smaller. Now, the funny thing about grade 1 is a lot of people have this and they have no idea that they even have arthritis at all, because there's no pain, there's no loss of motion, they don't feel it. Then you get into grade 2. Now, grade 2 is, if you look on the right part of that knee in grade 2, do you see how that little space there is a little bit smaller than the one on the left? It's starting to decrease.
On the right side of it?
Yeah, on the right side of that second knee.
Yeah, I can see that.
Pretty small, right? It's even hard to notice at that point. Grade 2, some people notice it. Some people have a lot of pain with grade 2, and then some people don't notice it at all. They're asymptomatic. But this is, when you get to grade 2, this is a patient who's had that problem for years, and they either, symptoms can come and go. Again, like I said, some people have no symptoms. Some people are in a lot of pain in grade 2. Then you get into the third knee, which is grade 3. Now, This is where most people can say, yeah, I can totally see the loss of space in between the bones. Do you see that right there on the right side?
Absolutely. Yeah, that one's really easy to see.
Yeah, easy to pick up. That's a problem that's been there for a long time. Almost everybody in grade 3 knows they have a problem because it hurts. It's stiff in the morning. It's more painful when you do more activity. And the problem is very, very obvious at that point. And then finally, you get into grade 4, which is the knee all the way on the right. And this is when most doctors would label this as bone-on-bone degeneration.
Yeah.
When you're in this grade, most people have a really tough time just using that joint. So we typically see people in wheelchairs, walkers. They've had tons of cortisone injections. They're usually like right on the border of having to have surgery, or they've already had surgery scheduled. That's grade 4. That problem's been there for a long, long time. That didn't happen overnight. It's just progressed over time. And so do these phases make sense to you, these grades?
Yeah.
Okay, Morgan, does this make sense to you?
Yeah, she's happy about it.
Okay, great. Now, what I'm going to do is show you your knee. So this, Sam, on the left is a picture of your left knee. Now, what do you notice is happening in your knee?
Well, the left side of it is really narrow. And then I didn't know none of those other ones had that like sharp thing on the side. You've obviously got an arrow going to it. So that looks uncomfortable.
Yeah, you're right. You're absolutely right. So you picked out the 2 major issues. On the left side of your knee, you have a loss of joint space. So the gap is smaller. If you look on the right side of your knee, that's what normal spacing looks like. That's what the other side of your knee should look like.
Okay.
And then you pointed out that little spike, that's what we call a bone spur.
Yeah.
And that's a sign that this problem has been there for quite some time. That takes typically years to develop.
Okay.
And so
one side of my knee is like healthy, and then the other is not good.
That's right.
Okay.
That's exactly right. So do you see how this would cause your knee pain?
Yeah. And it's funny because it's the outside of that knee. So, I definitely can pinpoint where the pain is coming from. So yeah, that makes sense. I don't really, on the other side, I just don't feel much over there. So that's surprising that there's that spur there.
Yeah, and I don't want you to get too caught up in where the spurs are and where the loss of space is in the bones, because some people have pain in different areas in their knees. So
Okay.
I don't want you to get too caught up in where the pain is, but the fact is you do have pain and you do have limitations, and you can see really clearly on the x-ray that the problem, it's been there for a while, and this is absolutely causing your pain. Now, you've done what most patients have, typically do in the past, is that, you have cortisone injections and pain medication and physical therapy, which works your muscles and tendons and ligaments. And a lot of those therapies are really designed just to reduce inflammation and cover up the pain for a period of time. And that's why, you've done those therapies, and you said they've helped a little bit, but they haven't actually fixed the problem.
Yeah.
Because clearly the problem with this x-ray, you can see the problem is still there. So the question I have for you is, if you do nothing about this, what do you think is going to happen to your knee a year down the road?
Well, I'm guessing we'll probably, as far as a year, I mean, I don't know how long it takes, but I'm guessing we're going toward that bone on bone stuff.
You're absolutely right. Yeah. So osteoarthritis is what's considered a progressive condition. Progressive meaning that it just gets worse with time. So it's not a matter of if it's going to get worse. It's just a matter of how bad and how long it's going to take to get to that point.
I see. Okay.
Does that make sense?
Yeah.
Okay. Now, so the big question I have for you is this something that you want help in correcting?
Yeah. I mean, yeah, I want to see, as long as it works, that's the thing is, it just, we're here to see what options are available, how much it costs, and whether or not it would work.
Yeah. Yeah. So great question. So I'm going to go through the therapies in a minute, and the therapies that we use here, we've used for a long time with really good success. And we wouldn't have you come back here, Sam, if we didn't think that we could help you. And I'm really confident we can help you.
Okay.
And the one thing, that I want you to understand as well is that this is, I totally just lost my train of thought. I had a really good one too.
I was touching on certainty of treatment. Like I'm interested, but I'm lacking. Maybe I just don't know why this, I don't want to pay a bunch of money for something and then have it be just another Band-Aid like I've been doing.
Yeah. Yeah. And that's a good question. And so what I want you to understand too, is that we would, number one, we wouldn't have you here if we didn't think we can help you. And the services that we provide are not designed to mask symptoms. And so we want to help correct the problem so that, 5 years down the road and 10 years down the road, that number one, you feel better, but also that your knee is functioning a lot better than it is today. So, what I was going to say is, and I totally forgot to ask you this question, Sam, is based on your x-ray, what grade degeneration do you think you're in?
I kind of look like that number 3, but with a bone spur.
Yeah, I agree. I think you're like late grade 2, maybe early grade 3. And the good news about that is that you're at a point where you can do something about it. And this is what I was going to say, is that when you get to grade 4, that's a situation where really the only options you have left are surgery. But because you're in between grade 2 and grade 3, you have the opportunity to do something about it instead of just waiting until it gets worse and then just having surgery as your only and final option. And so that's the good news. And the therapies I'm going to share with you are designed for patients just like you, where you're in this period where you have a problem, but you don't want to do surgery at this point. So you have options at this point.
Okay.
So let's go over those options for you. If you want to skip to the next page. So Sam, the first option that I want to talk about is hyaluronic acid injections. Now, you mentioned you had these years ago, and you said you had some good results, but they kind of the pain relief faded after a period of time.
Yeah, it felt good right when I did it, but it faded after a couple months.
Yeah, and that's by design. So hyaluronic acid, just so you know, I don't know if anyone ever explained this to you, but it's a natural substance that your joints produce on their own. And what happens is, over time, as we get older, as we damage our joints, your body can stop producing proper amounts of hyaluronic acid, and you can lose some of that cushioning and fluid that you have in your knee when you're younger. So what we do with hyaluronic acid injections is it's a natural injection. So this actually comes from the coxcombs of roosters. So it's not a steroid. So it's not gonna, as you know, with steroid injections, the more steroid injections you have, the more damage it does to your bones and the soft tissue in your joint. The nice thing about hyaluronic acid is it doesn't have those side effects. It's not going to damage your joint. In fact, what it does is it provides lubrication and cushioning. And what you'll notice, like you did before, is that you're going to notice that your joint feels better. You'll have less pressure on the bones and the cartilage in your joint. Your joints will move a lot better, but you're also going to have a lot less inflammation. So it's almost like WD-40 in your joints without any side effects. The only downside to hyaluronic acid injections is they typically wear out. So after about 6 months, you'll notice that the effects will start to fade. Now, what we do with a lot of our patients is after that period, we'll do a second round. And the nice thing about your insurance is they'll cover multiple rounds of hyaluronic acid injections, but you have to, they're not, it's a temporary fix, so to speak. So it's not doing anything to really correct the problem. However, it will provide you with what your goals are: less pain, the ability to do more activity with less pain and less side effects at the end of the night.
Yeah. Okay. Yeah, that makes
sense. So we do these injections in a series of 5. So Sam will have you come once a week, and each week we'll do 1 injection. So it's a 5-week protocol. And then after 5 weeks, we'll do an assessment to see how your knees are functioning after those injections.
Okay.
And then if you want to skip to the next slide. So the second therapy that we offer is knee bracing. Now, this is one that patients sometimes are a little hesitant about, because I understand that not everyone wants to walk around every day with a knee brace on, but let me explain what this does to actually help your knee. So this is not like a knee brace that you find at Walgreens, like a little sleeve that you pull over your knee. If you notice in this picture, there's a little hinge on that knee brace. This is called an unloader brace. And the design of that hinge, what it does is it actually supports that space on the inside of your knee. See how you have that little loss of joint space there?
Yeah.
What the brace is going to do is it's going to help support your joint on the inside of your knee to help open up that space. So it's going to take physical pressure off of your knee. It's going to help support your joints and ligaments, so that when you're playing with your kids and when you're coaching basketball, it's going to not only make your knee feel better and support your knee, but you're going to have less pain after doing those activities. Now, you don't have to wear this knee brace all the time, but if there are periods where you know you're going to be on your knees and stressing your joint and certain activities that you know are going to cause knee pain, slap this little brace on, and it's going to provide you with a lot of support during those activities.
Okay.
Also, when we combine the brace with hyaluronic acid and with the other injection I'm going to talk about in just a minute, it just helps your knee function better and heal faster. So it's going to give you some relief, and it's going to help you improve and get better faster.
Okay.
So that last hyaluronic acid is covered by your insurance. Your knee brace is covered by insurance. And if you click on the next slide, so the last therapy I want to talk about that's covered by your insurance is regenerative medicine. Now, this is a really amazing therapy. And the nice thing is it's covered by your insurance. And we weren't able to say that even 6 months ago, but this therapy has been around for about 30 years, and it's finally being covered by your insurance, which is really good news. So regenerative medicine is using human cells to help your body repair itself. And amniotic tissue, so some patients have questions like, what is amniotic tissue? Well, it's cells that come from the birth process. Now, this has nothing to do with abortions. Some people have that concern. But the cells come from mothers who voluntarily donate their placenta and amniotic tissue after having a scheduled C-section. So mom goes home with their baby. We use the cells for people with joint pain, just like you. So the cells are processed in a lab to make sure that they're safe. There are no known side effects of amniotic tissue injections because it's not a drug, it's not synthetic. It's just human cells and growth factors that we use to help speed up the recovery process. So the cool thing about this injection is it's a one-time injection. You should notice pain relief within the first 3 days. And what the injection does is it actually works to help repair the tissue in your knee. Now, this is the first type of injection of its kind that we've had access to in the history of orthopedics. Like you've experienced, cortisone injections, hyaluronic acid injections, while they can help with pain, they don't do anything to help repair the actual joint. This type of injection is the opposite. It's because it's regenerative medicine. Regenerative meaning that it can actually help your body repair itself. So this is the only thing that we know of that can actually stop and actually, in some cases, reverse the signs of aging in your knee. So remember, we talked about phase 1, phase 2, phase 3, phase 4 degeneration. This actually has the potential to stop that process from getting worse. How cool is that?
That's cool. Yeah.
So this is what you see like a lot of professional athletes getting, and celebrities have gotten these things for years. Well, we have access to this exact same technology that we can use for your knee pain. And this is a one-time injection. So we actually start with this injection first, followed by that series of hyaluronic acid injections. So this injection we could do, we can actually do this injection today.
Oh, geez. Okay.
And then the last slide, if you skip to the last one, the last thing here, and Sam, remember how I mentioned some of these therapies are covered by your insurance and some not? This is the one that's not covered by your insurance, but I want to talk about it because I want to let you know that this is an option for you and you can decide whether or not you want to do it. The reason I'm talking about it is we get really, really good results when we use knee decompression in conjunction with hyaluronic acid and knee braces and regenerative medicine. So this is that little device we had you sit on the last time you were in our office. And what it does is it gently stretches the two bones in your leg and it opens up that space where you have degeneration. So it provides pain relief, but it also allows your body to help to heal itself faster as we're putting hyaluronic acid and regenerative medicine into your knee. It just opens up that space to allow for better blood flow, less pressure, and increased healing. So this is a I don't want to say a permanent fix because it's not. It's a temporary fix, but it aligns. It just helps our patients get better faster. And you'll notice, like you did when you came in for your first visit, that it just feels good. And so this is going to get you back on the road to recovery and feeling better faster than not doing it. Does that make sense?
Yeah, that makes sense.
Okay. So before we go any further, are there any questions about the four therapies that we talked about, Sam, either you or Morgan?
No. And you guys checked our insurance. And so we do know that this stuff is covered, all that. I mean, I guess you said just the one thing, the knee, did you call it decompression? That wasn't covered?
That's right. Yep.
But everything else is.
Yeah. So actually we're going to talk about your insurance coverage and out-of-pocket costs right now, actually, if that's,
okay.
If that's
yeah, that's great.
Yeah. I just want to make sure you don't have any questions about the injections or the knee brace or decompression.
So I do have one question real quick about the regenerative medicine. So you said it stops the pain. I mean, I've read about like people, not getting knee surgery or things along those lines. So does it reverse? Like, I mean, what is it? Does it just stop where I'm at? I'm at a level 2 between 3 and I'm stopped there and I just can stay there longer, or what is actually happening?
It's a really good question. And that's a question we get really often. And the question I get is, well, does this mean if I have this injection that I'll never have to have knee surgery? And that's definitely not the case. Now, we've helped patients avoid surgery. We've helped patients that were scheduled for knee surgery and they had this injection and they still years later have not had surgery. And so the idea with this injection is we want to give your body as many chances as we can for your knee problem to heal without it getting worse. And this is an injection that has the potential to do that. So yes, it will help with pain, but it also has regenerative or healing components to it that will actually help your body stop and reverse those signs of aging. So, you're 40 years old now, Sam, and, I don't have a crystal ball, so I can't tell you that, you'll never have to have surgery ever in your life. Do I know if it's going to last for 3 years, 5 years, 10 years? I don't know. But what I can tell you is that most patients get several good years of function in their knee without having to have another injection. Okay. Now, because you're young and because you're in stage 2, stage 3 degeneration, my guess is that you'll have to do this protocol and this therapy over time. So I don't want you to think that this is like a one-time injection and this is going to solve all your problems with one injection. Is definitely not that. But I think that this offers this solution offers you, or this therapy offers you a solution that you can really help stop and reverse the speed at which your knee gets worse.
Okay.
Nope, I know that's a long-winded answer to a question, but
no, it's fine. That gives me the answer that I was looking for.
And what I'll tell you too, and we'll help you with this in our practice, is that there are a lot of things that you can do to help your knee stay better, which is maintaining a healthy weight. That has a lot to do with knee function. Staying away from, heavy drinking and smoking. Like, for example, we have patients that have done this injection and they're smokers and they don't get great results because they're constantly putting bad stuff in their body. Exercise is important. So if you, with your knee problem, if you just sit and become really sedentary and don't move your knee a whole lot, and your muscles get weak, this problem is going to get worse faster. And so the goal here is to get you back to normal activity where you can use your knee in a healthy way and not damage it more. But we want to keep your knee as strong and as mobile and as active as you can for as long as we can. And the more you can do to put your body in a good environment where it can stay healthy, the better off you'll be long term.
Okay, that's good. No, that all sounds really, really positive, really good. I'm liking it.
Awesome. So let's go over the cost. So if you skip to the next slide. Now normally, guys, so just a little side note. This is so this care plan I would go over. I wouldn't just show this to the patient up front. You want to go through it line by line. So what I would do is take a piece of paper and cover up the bottom portion of it. So the way I would do it is you start right at the top. So Sam, you have your plan. You have a $3,000 deductible.
Mm-hmm.
You've met $1,000 of that so far this year. So you have a remaining deductible of $2,000. So what that means is you owe that portion on your insurance plan before your insurance benefits start to kick in.
Okay.
Does that make sense?
Yeah.
Okay. So the first line in here, we talked about hyaluronic acid. Another knee visco supplementation is another word for that. You have a $20 copay per injection, and we're going to do a series of 5 injections. So 5 times $20 is $100. So that is your out-of-pocket cost for the hyaluronic acid injections.
Okay.
Any questions on that at all?
No.
Okay. Moving one line down, durable medical equipment. So that's the knee brace. You have a $50 copay for the knee brace, and that's just for your left knee. So that's $50 out of pocket. And then we have the next line down is knee decompression. So remember, this is the one that's not covered by your insurance. There is no insurance plan I'm aware of that covers it. Our rate is $50 per therapy session, and we're recommending 12 sessions, which is a total of $600. And then finally, at the bottom, we have the regenerative medicine injection. That's a one-time injection, and your insurance covers that. So there's no copay or out-of-pocket costs for that injection.
Okay.
So grand total for your therapy, and this would be all 4 of the therapies we talked about, is $2,750. And we can do that in cash, credit card, check, however you want to cover that. What makes the most sense for you?
Well, Morgan usually answers these questions.
Okay.
Sounds like she has a health savings account, so I think she just wants to use that.
Okay. Yeah, we can do that. Do you know how much you have in your health savings account?
It's maxed out, isn't it, honey? Yeah, she says it's maxed out. So in Idaho, that's I think $5,000. I think. I don't actually do this in real life. She does it. That's actually for real. She would actually make the decision.
Yeah. Well, no, that's why, Morgan, that's why you're here. So again, thank you for being here. Yeah, we can use your health savings account for this. So what we can do is go to the front, have a couple of documents for you guys to sign, and we'll take care of the payment. And then we'll go over instructions on today's injection. So we'll do the regenerative medicine injection today.
Oh, really? Okay, cool.
Yeah, so you're going to walk out of here feeling a lot better. We have a few documents for you to sign, and then we'll get a schedule set up for you to do the hyaluronic acid injections. The first one will be next week, and we'll go to the front desk and get those scheduled out.
Okay, cool. Well, sounds good.
Yeah, I'm really excited for you, and we're really looking forward to helping you with your knee.
Yeah, I'm excited too. So I want to back up just a little bit. I took a couple of notes as we were going, but I want to also say I tried to like feel like I was an actual patient. And so I'll tell you what I felt as I went through, because honestly, it was like, that was like the easiest close in the history of mankind. And I was trying to think, I'm like, is there a place in his report of findings where I would have thrown up a doubt that would have kept me from, doing something? And I didn't feel resistance. And I authentically did not feel resistance. So I wasn't trying to lob you a softball. I just didn't, I mean, without being, weird and fake, I couldn't think of anything. Again, I was putting myself in my dad's position. I was just talking to him recently about, this whole thing. And anyway, so That was one thing. One thing I noticed you were doing, and we covered this maybe last week or the week before, when you were going over each one of those therapies. The reason I really liked it is because you would go over a feature, you would attach the benefit, and then you would make it like, you would like say, this is why you need it. So you would like relate that to me. And I noticed that. I think I didn't notice that in the first one because I wasn't looking for that. But the second time, the second therapy was hyaluronic, the brace. You were talking about the brace, and you were saying how it like unloads the knee, right? And I was like, oh, he's explaining the benefit. Wait, hold on. What did he just? So I started taking note of that cycle, and I'm guessing, did you do that every time?
No, I did it I don't know if you noticed on the last training, I did it like very deliberately and like the same way every time. But this time I didn't. When you have 4 therapies that you're talking about, if you make the pattern way too obvious, then it can come off as authentic. And so I threw up a couple like, examples of your particular lifestyle. Like I just happened to throw in like, this is going to help you after you're coaching basketball games, so that the patient can actually now put themselves in a, in a real scenario in their life. Like, oh yeah, they can start to imagine themselves feeling better after coaching a basketball game, which kind of future their success.
Yeah.
So it was a little more subtle this time, but I also wanted to make it really like, I don't know, kind of boring in a way.
So like you had a cautious certainty, and meaning you were certain about the treatments, but when questioned about, regenerative medicine specifically, you gave a response that reflected both cautiousness and certainty. And I wonder if part of that comes from like, and we're getting questions about about stuff that is not really about reported findings. It's more about regenerative medicine, which 100% we'll get to here in just a second, I promise. But I wonder does that come from like the pressure is kind of taken off because insurance is covering that thing in particular? Would you have done the exact same thing because this is news to me, as far as them being covered by insurance. And I think most of the doctors that watch this are watching this now, or even on replay, it'll be news to them. And again, I don't want to get into that just yet, but I want you to put yourself in the position of, if this was a cash service and I asked you the question that I asked you, which was basically, does this thing actually work? That was the underlying tone, because that's what most people want to know.
Yeah.
Would your response have changed?
No. What I noticed was, when I first started doing regenerative medicine, this was like 6 years ago, and we charged $5,000 an injection. My natural instinct when questioned about its effectiveness was to overplay the benefits and be like, oh, this is like the greatest therapy ever. And like, yeah, I really think this is going to help you avoid surgery, and you're going to be able to do all the things you want to do. And like, it in many cases sounded too good to be true. And a lot of it, to be completely honest, is I wanted to close $5,000 cash care plans. It's great for the clinic. And what I noticed over time as I matured through the process was, the more that I didn't do that, the more that I was just completely, here are my cards, here's what I expect will happen, here's what could happen, here's what might not happen, the more people would be like, oh yeah, okay, that makes sense. And when you're brutally honest like that, without any apparent motivation,
yeah, patients
will they connect with that, and they're looking for that. They want to see if you're going to like try to oversell it or undersell it. And what I found was, if you're just honest, and that took a lot of training for me to do that, to be honest. but yeah, the more honest I was in terms of expectations, the better the outcome was.
Well, and also this kind of, as you're talking, I'm thinking back to the previous trainings we've done, and even trainings I've done for people on the sales process. Whenever the delivery of the information is not internal, meaning you don't own the information, you're just like, oh, I'm regurgitating it, then your subconscious does not match the reality of what's coming out of your mouth. So meaning, I say words one way when I really believe them. and I say the exact same words, verbatim, phrases, differently if I'm not, like you said, confident about them. So
That's a really astute observation. That took me a long time, Sam. I think we should repeat that. That took me a long time to learn.
yeah,
Because the person that I learned regenerative medicine from was a very like hard pushing salesperson and would probably say anything to get a sale. And some of that I took with me as I learned it. And I just picked up some bad habits, which is that's not how I am normally. Like I'm not a pushy salesperson, but I sort of adopted those sales tactics. And the more I did it and the more I kind of found my own voice and what was authentic to me, it just, man, I did so much better from a business standpoint that way. And just using honesty and just being ethical.
yeah. No, I like that. I do have one. I don't know if it's a criticism. And I don't know, I honestly, because I'm not a doctor, I just know like if I were selling something else, this is probably what I would do. Right. One of the things I really love about this approach is you're not just saying, okay, here's a regenerative medicine shot, you're going to be good to go. All right. And I know there's people that do that. And I'm not a doctor, so I can't say whether or not that's all you need, but I can tell you from the lay person, that seems like, hey man, you just charged me a boatload of money for 1 minute's worth of work. I don't feel an equitable amount of exchange here. When I look at the knee viscosupplementation, the DME, the decompression, regenerative medicine or physical therapy, when I see this, I think, hey, I don't know why, but this feels better, right? And I think the opportunity missed is one of the things that I would have probably done is I probably would have pre-framed something. I call it, when we do our ads for knee stuff, we actually call it a knee or a joint restore program, right? And so I frame out something that we created that's nuanced to us. And the reason I would say today we're going to go over your custom results and we're going to show you how we frame them inside of something we call our knee restore program. We call it a knee restore program because our goal is to not just use one therapy or one surgery to fix the problem. It's to add lubrication to it, it's to add more space to it, is to add new cell growth. So we're going to show you an entire restoration, almost like you'd restore a car. We don't just slap a new coat of paint on it. Right? We're going to show you a knee restore program. So by the end, our goal can be focusing on how to resolve this problem for a long term. Again, not guaranteeing that you won't eventually have to have something more invasive or interventional, but for the time being, we can give you a restorative approach, something like that. You know what I mean?
I just realized this, and this is how rusty I am at actually doing reported findings. I totally forgot to mention right before, when I introduced myself to your wife, Morgan.
Yeah.
I didn't preface this is that you guys have just watched a 14-minute reported findings video that talks about that's what we call it. We call it the knee restore program.
Oh,
I don't know if you go back to the slides, there was like one of the slides, the first one had a play button on it. And so what I was supposed to say at the beginning of this training was, hey, Sam and Morgan, that's it. Yeah. So thank you for watching that video. And that video describes the 4 pillars or the 4 aspects of our knee restore program, which is lubrication, physical therapy and rehab, regenerative medicine, and stability. Like those are the 4 pillars of it. And so before you guys even talk to me and before I go over all the components of it, they already know, okay, because
you asked me if I had any questions. You were probably asking me if I had any questions about that.
Dude, yes, probably. Again, like I am very rusty. This is the first time I've done it in years. But yeah,
it was great. Yeah.
I botched that. And we talked about this on the training before the last couple of weeks, is that you want to have some kind of pre-education process. So what we do for our offices and our clients is we give them it's a 14-minute video. It talks about, how all these components fit together so that it's an actual program, not a one-hit wonder therapy. Like you go to your orthopedic surgeon and they slap some cortisone in the joint and then, all right, come back when it hurts. Like that's not our approach. There is an actual structured program that we take people through. And I think patients like programs. They like to know that there's a system, and that the
Yeah.
system that we're using is a different system than what they're used to that hasn't worked already. And you can do this in a video form. We do that because it just saves a lot of time in offices. We used to do this in a group report. So for example, when we did regenerative medicine on a cash basis, we would get 20, 25 people in a room, and I would do a 1-hour lecture on regenerative medicine. And the 1-hour lecture was designed to qualify or disqualify that person for care.
Mm-hmm.
So we'd have half the group, you'd be like, oh, this is great. I want to see if I'm a candidate. Or the other half would be like, no, not interested. So we're kind of like weeding them in and out. But my point in saying this is you should absolutely have, before you go into the recommendations, you should have some sort of patient education process that pre-frames and that sets up the conversation that you're about to have. And in that video, we have this really cool testimony of a patient who was facing knee surgery and went through the program, and he's like, I was skeptical about it, but you know what, I'm so much better now. And he was tearful in his testimony, and that's how we end that video. So there's an emotional component to it, and it's a real live person who said they went through the program and it helped them. And I think that's a really
and there's another component missing too. I mean, in this explanation, this is all important. Education is important, but the other thing is, like anything, there are services that will transition from a nuanced, high ticket service into a commoditized, cheaper service. All right. And so one of the problems that you're going to have in actually closing these care plans, these cases, has nothing to do with a doubt in that person's mind of whether or not they want to do it. It's more like, hey, can I get it cheaper over there? There's other people doing this. Okay. So when you present a program that is nuanced and created by you, okay, then it basically decommoditizes that service. And a decommoditized service then has no price tag. Okay. Because if they're not going to get this exact same program when they go down the street. Okay. They're not going to get the ABC integrated medicine knee restore program. They're not going to get that. And so if you have sold them on the fact that they need all of these things and why they need each component to combat your particular case, then I will tell you 100%, my wife, Morgan, right here, she will leave this clinic and she'll be like, let's see if we can get it cheaper somewhere else. That's how she rolls. In fact, I hate shopping for Christmas presents for her because she's like, you could have got that for like $20 cheaper over here. I'm like, oh, jeez, just have some money. Go buy it yourself. The point is, I wrote this down, setting up your own niche program and presenting it in that way is going to allow you to decommoditize your service. And that's really important in closing and creating interest and desire. Authenticity, certainty, that was awesome. Great. I mean, overall, it was awesome. I'm going to ask if anybody has questions. I definitely know. Do you want to, while people are coming up with questions, Dr. Wells, we've got questions coming in about the amniotic tissue injection. What some more details on that? I mean, just whatever you want to share on that.
Yeah. So amniotic tissue, there are codes now for amniotic tissue regenerative medicine. So this is the same. By the way, this is what doctors call, I'm doing my air quotes, stem cell therapy. So this is nothing to do. Most doctors are not doing stem cell therapy, where that's where you're taking it from the patient's bone marrow or from their fat.
Right.
Most patients are outside the U.S. So amniotic tissue is a part of the umbrella term regenerative medicine. And this is what doctors are typically charging $4,000 to $6,000 for. Most commercial payers now have codes that they'll reimburse. Not only will they reimburse it, they'll actually pre-authorize the injection so that you know that you're going to get paid on it before you do the injection. So instead of having to do these group lectures and seminars and the really big dog and pony show, you can now bill it through most private insurance. Medicare pays on it as well, but I just want to caution you that Medicare does not have the same pre-authorization process as commercial payers. Some doctors are billing this to Medicare. I think that's a mistake, and I think that's a potential for an audit. But the private payers, commercial payers like your Blue Cross, Blue Shields, Uniteds will tell you in advance whether or not they'll pay for it. They'll approve it. So that's what we're using now. We have a pre-approval process. We have an actual product that has a code that you can use for patients, which we didn't have before, which is really exciting. The biggest question I got with regenerative medicine for years was, when does my insurance cover this, or when will insurance cover it? And we just never had a good answer for that. But now that therapy has been proven. It's been around for quite some time, and it's cool that insurance is starting to cover it.
Cool. And maybe we can do a training just dedicated to that in the future, you guys, if you want to see that. Jim says, what do you tell people that don't want to prepay or pay each visit?
Yeah.
I'm guessing he's saying versus pay per visit.
Yeah. So what we tell patients is that, and what I would always address that with, like, hey, that's a really good question, Jim. So the reason we don't do that is that if we had patients pay every time they come in the clinic as a busy clinic, we would have to hire 1 or 2 people just to take payments over the front counter when they come in. So instead, what we do, and the way we keep some of our costs down in our clinic, is we just have patients pay for it up front. Now that the question I always get is, well, what happens if I can't continue my care? Or what happens if I decide I just don't want to follow through with care? Well, the good news is that if let's say you've paid for everything up front and you decide halfway through, you know what, I don't want to do it anymore, we will refund you anything that you've paid in advance, or any service that you haven't received up until that point. So just know that you're not, there's no contracts here. You're only paying for what you receive, but that's how we help keep our costs down, and that's how we keep our costs down for you as the patient. And that's why we do that.
It's interesting too. I would say, Jim, and to anybody else asking, if you, and this is going to change per location, by the way, if you have a objection that comes up frequently, first of all, you need to analyze, like, why is this coming up? What am I saying that is bringing this to the forefront? Okay. That's like number one. And then number two is you can always tackle, this is something as a copywriter, when I write sales letters or things like that, or scripts, I'm waiting to find the objections, the doubts, the whatever. And then before I even give them a chance to talk about it or to ask questions about it, I answer it. So I might say something like, in my pre-framing, Jim, I might say something like, so I'm going to share our plan on how we're going to our knee restore program. We'll go through each line individually. At the bottom, we have a total. Okay. We have some payment options for you to handle that. We'll square that away, generally in one lump sum payment, or we have other options. And that's how we do it here at our clinic. Obviously that's not rehearsed at all, but I would just say from the beginning, if that's something that's coming up frequently, I would say, this is what we do, and this is how we do it. And not even why. I don't know that I would put in a why. Anytime you got to be careful about throwing in your whys, because sometimes they can come off as defensive. So whenever somebody explains themselves too much, that can be perceived as defensive. This is more of a treatment question. Let's see here, where to go. Is amniotic injection similar to hyaluronic injections at all? Like they can be repeated every 6 months or anything like that?
Yeah. So it all depends on medical necessity. But yeah, if you can prove medical necessity. So for example, hyaluronic acid, Medicare will pay that every 6 months. There's a way to document that. So you have to prove medical necessity, which is pretty easy to do. And the same thing is true with amniotic injections. And the key there is you want to get a pre-auth before you do the injection.
Yeah. And that's the same thing with x-rays, if you want to get another set of x-rays, as long as there's an existence of pain. Isn't that the threshold for, like, as long as there's pain, then you can do that?
No, not so much pain. Pain is not a good, reason to do these types of injections. An x-ray is typically there's a medical protocol that to prove medical necessity, but yes, you have to have pain, but there are other components to it.
Mm.
One thing I just want to say is that there are right now, disclaimer, there are a lot of groups who have jumped on this bandwagon of Q codes and amniotic tissue covered by insurance. A good chunk of them, I know from experience, are not doing this legally, and they're trying to sell a product. So I've been really cautious and patient with this process, and I've seen this coming over the last 2 years. And I've talked to quite a few attorneys on the right way to do it. And also there's a way to do it that's going to get you audited for sure. So what I would say is if you're going to do this or considering putting it in your clinic, please, 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 please hire, it doesn't take a lot of money, hire a compliance attorney, let them know what you're going to be doing or what you anticipate doing, and let them give you some guidance on how to do it properly. If you're relying on me or any other vendor or a consultant to tell you what is legal and compliant, you're going to end up in trouble.
Yeah.
Now, I'm telling you that not because I'm being unethical in what I'm doing, but there are a lot of players out there that are giving out some very, very dangerous information. So I would caution you, if you're going to do this, don't do it unless you contact a compliance attorney first. And I can't stress that enough. There's going to be a lot of docs who are doing this. I know for a fact are doing it wrong, and they're going to pay for it later.
Well, it's funny because you and I even talked about this exact same thing. I mean, since I do marketing for so many clinics, I get people coming to me and asking me, hey, do you know people that are doing this and that and the other? And, you know, I do. I know people. In fact, we were working with a guy like 2 years ago that was doing that one thing where you do like an injection or insertion behind the ear. Do you know about this?
Yeah, that's a great example of like this P-Stim device or this
Yes.
selling it hard. Like Medicare is paying $8,000 per case.
Oh, this guy was making like $10,000. And so while I know about that, there's a couple of people that I go to. I'll go to you and I'll go to Sunny, and I'll be like, hey, I heard this. What's the truth? And I know it's really funny that, and by the way, we didn't rehearse today's role play at all. We talked a little bit. And I said, hey, what if we set up this scenario? But other than that, I wanted it to be as authentic as possible. And you and I have talked previously about, you know, Q codes and things like that for regenerative medicine. And you had always been like, nope, not yet. Nope, not yet. And so this is a new, and I know you have a compliance attorney that you reach out to, and they just had been giving you, you know, they had not been clearing you for takeoff. And now it sounds like that's now changed.
Yeah, you know, you and I get hit up with all these like new concepts and new ideas, and the first thing I do when I hear something new is I just contact the attorney, and the attorney can look up how to properly apply these therapies and codes. It's all written, and if it's not written, then you're going to get yourself in trouble. So that's the first thing I do is consult an attorney, healthcare attorney. And so I'm saying this to say, hey, don't go out without doing your research and talking to an attorney on whether or not you should do it, but also then how to do it.
Yeah.
So many chiropractors get in trouble because they don't know that they should talk to an attorney first. And it doesn't cost a lot of money. My attorney charges me about $500 to research a new therapy. And he gives me I have a couple that I use, and he gives me just really straight advice from an attorney who knows the game, not from a vendor. Vendors are trying to sell stuff and they want you to use their product, but that doesn't mean that they're giving you the proper information.
I love it.
I don't know how this turned into a compliance call, but but it did.
Well, I mean, you know, that's the beauty of what we're doing. I mean, this is authentic stuff. I mean, New Patient School again is about getting new patients. Patient Stream is an awesome software. It allows us to run Facebook ads without a person effectively. And if we've got new conditions and niches, we're all about the niches. If you've heard anything I've talked about, I don't believe that there's such a thing as quality patients. I think there's qualified patients, and there's a distinction there. And so, you know, this is new information. I assume that this means that we will have some new niches and offers coming soon in Patient Stream with this new information because, you know, I mean, geez, both you and I know that if we can help any clinic grow, make more revenue, thus getting, having the ability to help more people, man, we're doing our job. We're over our time limit. And so here's what I'll say. If you have any questions about any of the, well, first of all, I'll have the replay. It'll be in the Facebook group. If you're not in the Facebook group, you should. It's Patient Stream Users Group. I'll also have it on my YouTube channel. But if you have any questions about that, feel free to tag Dr. Wells in the Facebook group. If you're looking for help on any of the compliance stuff or any of the, the things mentioned, just reach out to him directly. What's an email that they could reach out to? It's aw@simplifiedintegration.com. Is that right?
Yeah, I'll tell you what, I'll type it in the chat box here.
Is that right? aw@simplifiedintegration.com.
That's it. Yep.
Okay. So if you have any questions or want to reach out to Andrew about whether integrating your practice, this protocol, this is a real protocol, by the way, or anything else, then just go ahead and reach out to Andrew Wells. So thanks, guys. Appreciate it. See you on the next one. Thanks, Andrew.